Good evening. Welcome to our Operation CPAR Conflicts, the final attachment frontier. Good Star Trek theme. We appreciate you taking the time this evening to come and to join us. And it'll be several parts. We're going to do some presentation and then we'll have some time for Q&A at the end as well. Next slide. So just to let you know, we will be recording this. It may be posted either on the website, our website, or to YouTube. So just be aware you may be recorded if you're asking questions or making comments that you know that might be recorded. Next slide. The next slide is the land acknowledgement. The AMA respectfully acknowledges that we live and work on traditional lands of many diverse distinctions-based Indigenous peoples. The AMA honors the vibrant histories, languages, and cultures of the First Nations, Inuit, and Métis people of Turtle Island, now known as Settler Canada, who came before us and continue to thrive here today. We are committed to meaningful reconciliation and holistic health for all. We invite everyone to reflect further on how you can contribute to meaningful reconciliation, including actions that move us toward holistic health for all the relations who host us. Next slide, please.
CPAR Conflicts, the final frontier. These are the voyages of the Alberta healthcare system, its ongoing mission to improve care continuity and patient attachment, to reduce admin burden and improve system integration, to boldly go where few patient medical homes have gone before.
There you go for all you Trekkie fans, a great introduction. Our speakers this evening are Dr. Trevor Day, ACTT physician leader and SFM executive, and Dr. Andy Baines, an ACTT physician leader as well. Dr. Day is an Edmonton-based family doc and is on the SFM executive. Dr. Day will start us off with some background and context for the webinar and will act as one of the panelists at the Q&A session at the end. Dr. Baines is a Calgary-based family physician and ACTT physician leader, and will be delivering the bulk of the content around today's main topic, which is CPAR conflicts. I'd like to thank them both for joining us and sharing their expertise. And with that, we'll give Dr. Day the floor, or the airwaves, as it were.
Great, thank you, and good evening, everyone. Thank you for joining us. I'm going to do the worst Scotty impression that you folks have ever heard in your life. But we're all doctors, Captain. We're not historians. How did we get here? That was bad, and I'm sorry that this is recorded and that will forever live on the internet. Yes, so we are on the last leg of a decade-long journey, and I will take you through a little bit of history just before we set our tasers to fun and hand it over to Dr. Baines. Next slide, please. So in the beginning, I want to start by recognizing where conflict sits in the broader context of Alberta's journey towards improved care continuity and stronger patient medical homes. So as mentioned, this has been a decade in the making. And over a decade ago, when electronic medical records were transforming community-based care, information was still existing in silos, and there was very little information that was being shared throughout the entirety of the healthcare system. So while hospitals and other critical government-run agencies were integrating and improving information sharing, no such integration was available for the thousands of community-based clinics and physicians. This meant that there was no effective method for identifying yourself as the primary care provider to others in the system, and very little or no information about primary care services visible to others in the system. So to use another pun, you couldn't beam up the information, you couldn't beam up the consults, and unfortunately the patient was left out there dangling in space. Alberta physicians recognized these informational and relational continuity gaps and advocated for solutions. So a motion at RF led by community-based specialists demanded a way for consult reports from community clinics to be uploaded to Netcare. The section of family medicine also requested a provincial patient attachment registry and a way to share basic information about primary care with others in the system. AMA physician leaders championed these causes and the government heard us. So in response, the Community Information Integration System, or abbreviated to CII, and the Central Patient Attachment Registry, abbreviated to CPAR, were created. Now, nearly 10 years later, these systems have created one of the most integrated healthcare systems in our country while maintaining a diversity of EMR choices for community-based physicians. So today, nearly 90% of eligible PCN physicians have opted into CII and CPAR, and over 2 million consult reports have been submitted to NetCare from community-based specialists, strengthening attachment and improving continuity of care for all of our patients. I want to thank those physicians for pioneering such a system integration and boldly going where no patient or physician had gone before, and all of Alberta physicians for their patience and perseverance in making it such a success. And for family physicians and rural generalists that have been hearing us talk about CAI CPAR for nearly a decade, rest assured that managing conflicts is the last big step we're asking you to take on this journey. Next slide, please. So there's lots of good medical evidence to show that relational continuity does benefit patients. It improves a whole number of factors in patient care. It benefits the system in terms of cost savings and patient satisfaction, and it increases the quality of our care as well. So there's lots of studies out there, and the evidence summary will be available on the AMA website, and it will be included in the email after tonight's webinar. Next slide, please. So as family physicians and rural generalists, continuity of care is the cornerstone of our profession. Maintaining a current and accurate panel isn't just good practice management, it is also a professional requirement under the CPSA standards of practice. So the continuity of care standard of practice and the transfer of care standard of practice touch on these aspects as well. When our panels are inaccurate or conflicted, it makes it much harder to make sure that the right provider is receiving the right information at the right time for the right patient. Accurate panels, which also includes depaneling patients appropriately when they've moved on or when they've chosen another provider, are essential to ensuring the information reaches the right person at the right time. This is why the section of family medicine strongly encourages all of our members to take advantage of AMA-ACTT CPAR resources. These tools are available to help you deliver the highest quality care, to protect your patients, to support your practice, and to maintain your CPSA compliance. So with that short little history out of the way, I will hand it over to Dr. Baines, who will take us more through managing conflicts. Over to you.
Thanks, Trevor. Hi, everyone. And I apologize in advance. I will not be able to match Trevor's awesome Star Trek puns. I am not a Trekkie, but I will try. I think I can think of one. So wait for it. You'll have to pay really close attention. Before we begin, we just want to start with a few definitions so that everyone is on the same page. Our learning objectives are going to start with explaining what CPAR conflicts are and then why lowering them improves continuity. We are going to also teach you about why implementing a clinic process and sustaining a low conflict rate is important. We're going to help you dispel some common misconceptions about conflicts. We're going to help you understand how conflicts might impact physician income. And we're going to apply conflict activities to show you how you can fulfill a PIP requirement if you need to. And lastly, we'll talk about some tools and resources to support conflict work. So on to the definitions. So many of you here are going to be just learning about conflicts for the first time, and there's going to be others that have been working on this for quite a while. So for some of you, this might be kind of old hat, but before we dive in, let's just all get on the same page. So CPAR, Trevor mentioned, is the Central Patient Attachment Registry, and it's Alberta's favorite method of paneling patients. On your CPAR panel, your name is then listed on the patient's NetCare profile. So that helps others identify that as being your patient. And then CPAR conflicts occur when patients are included on more than one provider's panel. So on NetCare, there will be multiple providers listed as that patient's primary provider, and then they'll show up as a conflict. We're going to talk more about what conflicts are to come. And then finally, the conflict rate is another term we're going to refer to. And this is basically the number of conflict patients, the number of patients on your panel that are on other people's panels divided by the total number of patients on your panel. And it's we talk about it as a percentage. So this might look a little bit overwhelming, but it's not. It's kind of just background info for your interest, but it's pretty neat. This is something that many of us follow. If you're kind of in the PCN world, you might have heard about conflict rates and how they're going up. So what you'll see in the top green bar graph is over time, the number of patients in Alberta going on to CPAR because their primary provider is going on to CPAR. And so that grew over the years. And now, as Trevor mentioned, we're seeing really good uptake of that. And then the second bar beside in the gray is the number of patients in conflict going up. So of course, as more patients are going on to CPAR, more conflicts are going to occur. So that makes sense. And then in the lower graph is a line graph kind of showing conflicts going up with time again, but in more detail, you can also see that there's times where it plateaus and even goes down. So what that's demonstrating is that people have been doing really good work and working on their conflicts over the last few years. And we're starting to see things stabilize around 12% in the province. So 12% of Alberta patients are currently in conflict. And our goal as a whole is to try and get our provincial conflict rate down to something like 5%, which is ambitious, but I think reasonable. If everyone starts working on this and over the years to come, we might kind of see that being our new baseline, which would be really neat. The left hand side shows another bar graph in the navy blue, which just shows the different zones and their different conflict rates. It's not a competition, but we can make it one because that's fun and motivating. But of course, it's hard to kind of compare all of these different parts of the province. You'll see that the rural areas with north, central, and south zone have lower conflict rates than the big cities. That makes sense because, of course, in smaller centers, patients are doing less multi-doctoring. They're probably more kind of continuous with their main clinic. There's also less, options. Whereas in the city, there's lots of different clinics and people are kind of moving around a lot more. So we're going to, of course, see higher conflict rates in the city. But we also know that some of the zones, like North Zone, they've been working on their conflicts really hard for a long time. So I think North and South Zone and Central Zone, they're part of the reason why their numbers are looking really nice there is because they're doing really good work to get their conflicts down. So we'll just go to the next slide. So we're going to talk a little bit about some of the common causes of conflicts. So we're going to see that, there's patients that are moving, changing providers, and then the old family doc doesn't necessarily know that their patient has left them and started seeing a new family doc. So that's one common reason. We've got patients that are routinely just kind of seeking multiple opinions and going to lots of different clinics. So we know that happens, which isn't ideal, but that's the reason for conflicts. We've also got some clinics that are inappropriately paneling patients for episodic care. So perhaps they're a walk-in clinic or a specialty clinic, and they may not know like the difference between how to panel a patient in their EMR versus label them differently in their EMR. And so we're seeing some of that happening and causing conflicts. We're also seeing that sometimes providers have just gone onto CPAR and they haven't cleaned up their panel in years and years or maybe ever. And so they're going to have tons and tons of conflicts while they, get used to this new idea of paneling and keeping a clean panel. And then there's sometimes legitimate reasons why patients are in conflict. And we call that, those few legitimate reasons of why there might be a conflict, where we term that appropriate dual attachment. So we're going to talk a bit about appropriate dual attachment on the next slide. So appropriate dual attachment is a very small percentage of conflicts. And so there are some cases where we don't need to resolve every single conflict. And that's why we're saying, 5% conflict rate is probably reasonable, because you're going to have some that we just can't rectify or that don't need to be rectified. So for example, there might be a patient who, lives mostly in Calgary, but then works in Fort Mac for half the year. And so they need maybe a doctor in both places. And so it might be appropriate for you to just let that patient be a conflict for you. And then the other reason why we're seeing sometimes appropriate dual attachment is with maternity care. There are some maternity docs who are wanting to panel patients while they are looking after them for maternity care, because when you panel a patient, you also receive e-notifications through your EMR every time that patient goes to emerge, is admitted or discharged, and they're wanting that information quickly, like how the e-notifications work. Now, most maternity clinics are not doing that. The few that are, they've chosen that that's important to them. And I think if that's the case, hopefully they all have a good process whereby at the end of that patient's maternity care, once they've delivered and gone back to their family doc, they're routinely unpaneling those patients so that they're no longer in conflict. So those are the few reasons why we're seeing kind of appropriate dual attachment. But for the rest of this webinar, we're going to be talking about conflicts that are not appropriate, or those that should be resolved and that we should actually be working on. And we want to touch on briefly why this is actually important, because it is a bit of work for everybody. So I think it's good to understand what are some of the long-term goals and why are we actually doing this. So some of the impacts of unresolved conflicts are listed on the next, here they are. So the first thing is that when you have a conflict, like we mentioned, both providers are listed in NetCare as the patient's primary provider. So this is kind of confusing. It sometimes makes it so that acute care staff aren't sure who is the actual primary care provider. And then they're sometimes pulling that data and putting it into Connect Care, and they don't really know who to put into Connect Care. And this might result in both physicians getting unnecessarily copied on documentation from hospitals and specialists. It can also result in it going to the wrong doctor and not the right doctor. And it also might result in you, if you're kind of having a patient in conflict, getting calls and instructions for follow-up from patients that aren't really yours, which can be stressful. And then the other thing is that when patients are in conflict, um, panel size reports are going to be less accurate. So those of us that use the HQCA panel reports, which is a whole bunch of information about your panel, you get screening rates from that that are really accurate. And so if you have, of course, a panel that isn't completely accurate, your screening rates are not going to be accurate on those types of reports. And it's not really giving you your true panel size when you have a lot of conflicts. You don't actually know how many of those patients are yours. And then you might actually have capacity to take on new patients if you kind of update that and work on your conflicts. And then lastly, of course, with the new payment model, the PCPCM, there is some financial impact when we have lots of conflicts. And we're going to spend some time at the end of the presentation talking about that. So on this slide, we just have an example of a poster that's available for offices if they want to put it up in their waiting room. It just kind of is educational for patients about the importance of continuity, and something that we can use to start conversations to educate our patients that are perhaps seeing multiple providers for no clear reason, about how it's important to, see the same person, how it's good for your health, results in less referrals and screening and duplication. And, for yourself, hopefully with lower conflict rates, we're also going to see other benefits like less admin burden. And like we mentioned, more accurate panel sizes, better reports, screening rates look more accurate and such. We're going to provide links to resources such as this poster in an email summary. So if anybody wants to use these types of things to start conversations, you can download them and print them. All right, so now we're going to get a little bit technical and talk about how to get CPAR reports and how to look at them. So the person that downloads your CPAR report is called your panel administrator. And that person can log into CPAR to see details about the panel submissions and a bunch of different reports, including panel size and your conflict report. And so this panel administrator, it can be PCN staff if you have access to that kind of support. It can be your clinic staff, so you could have your MOA or manager a little bit trained on how to do that. And sometimes PCNs can support the training of the staff in the clinic, or just kind of the informational part so that they understand how to log in. But you can also be your own panel administrator. So if you are a physician that's really doesn't have a lot of PCN or MOA support, you can also just choose to be your own panel administrator as well. And you can have multiple panel administrators. So if you're not sure who your panel administrator is, you can email this eHealth provider support email. And again, that'll be in the resource list so that you have that on hand, and they'll kind of help you figure out who is your PA or panel admin. So whoever the panel admin is, when they log in, this is what the login page looks like. It's a pretty straightforward website. In the portal, you can see there's a little red square. The left-handed red square shows all the different types of reports that you can download. And so that one of them is going to be the conflict report. And you can also see on their panel submissions, like from your EMR up to CPAR, if you're kind of trying to figure out why your PCPCM panel payments say you have this many patients and what they're actually saying. There's an area on this where it can tell you your submissions over the previous 6 months. So that can be quite helpful. So let's say you have downloaded your conflict report from this portal. Now we'll look at what a conflict report looks like. So this conflict report is an example, and whoever's conflict report this is deserves a gold star because they only have 2 patients in conflict. So I can pretty much guarantee that nobody in this webinar is going to have this beautiful of a list. Likely, we're going to be measuring our conflict reports in the number of pages. But let's imagine this is your list. So if this is your list, I'm going to walk you through just kind of what kind of data is in here. So we'll look at the first patient there, Janet Doe. It's going to give a little bit of her information, and then it's going to tell us in the kind of green highlighted area, the last time this patient saw you and the last time your clinic validated this patient or confirmed this patient. That's the confirmation date. So for those that aren't familiar, many EMRs, I think probably all EMRs have some way of showing you validated the patient. That means when the patient checks in, usually the staff are saying, is this still your phone number? Do you still live here? And are we still your doctor? Yep, cool. Okay, validate. And that kind of keeps up-to-date lists of, patients' demographics and as well as their attachment to your clinic. So sometimes the last clinic date and the validation date will be the same. And sometimes it won't be the same. Like it's not like we validate every single time. Of course, it's missed. And that is something that some PCNs measures, like validation rates. And we aim for kind of doing that 80% of the time sometimes. So that's kind of that first couple columns there. The area that's kind of labeled with the red labeling is the conflicting clinic. So for Janet Doe, she has a conflicting clinic, Elm Street Family Care. This patient is also paneled to a doctor there, and it also lists the last time they were seen at that clinic and the last time they were validated or confirmed at that clinic. And so you can see that, in 2024, they've been kind of seen by you, and 2021, 2022, they were seen by this other provider. So probably this patient is yours. They probably left the old clinic, but, it'd be, we'll talk about what you're going to do later in terms of figuring out who they're actually seeing. And then in the second line, a similar kind of types of information all there, but this time, the last time David Silva saw you was a few years ago, and they've since seen a Dr. Nancy. And so this patient might have actually moved on from you to see a new clinic. So this is a very neat list that doesn't need sorting, but since most of us are going to have very long lists, one thing that you can take and do with it is you can actually sort these. They're a spreadsheet, so you can use Excel or Google Sheets or other types of spreadsheet software to sort these lists. And you might decide to sort them by patients that have not been seen by the other clinic the furthest time away from now, because then those patients are more likely your patients and not seeing that other clinic. So you might choose to sort it by that date, the date of the last visit for the conflicting provider. Or you might choose that you want to kind of see which patients are probably not yours and sort it by the date of the last time they saw you and start with the ones that haven't been seen in 5-10 years and kind of clean that up first. So it's neat. You can decide how you want to sort it using your software. And part of the process that we're going to talk about later is deciding how you want to sort and tackle this. So we're going to talk a little bit about processes now and how to manage these lists and how to deal with them and make a plan. So let's start by talking about what the physician's role generally is. So the physician's role is generally to start the process and kind of as a clinic, talk about it with your team, decide that you're going to work on this, motivate people, educate your clinic as to why we're working on this, because sometimes we as the physician know what the end goal is and what we're working towards and why we're doing something. But when we're asking our clinic to help us and our team to help us, I think it's really important that we all kind of see what the point is. So yeah, part of the process is going to be sitting down probably as a clinic and determining how we're going to tackle this as a group. So you're going to try to develop a policy or process together. You'll probably also want to be involved in approving the scripts that your staff use when they're calling patients. And the fax templates that they're going to use to fax the conflicting clinics, and maybe the charting templates that you might, in your own charts, you might decide that you're always going to create, for example, a task or a notice every time you unpanel a patient. So you probably want to be involved in that process of figuring out how what's written in these things. And then you will probably be involved in deciding who's the panel admin at your clinic and how often are we going to, recheck the conflict rate. Are we going to do this every 3 months, every 6 months? And you might also want to talk with your clinic about how to deal with more complicated conflicts. So, if your staff calls a patient and they say, oh, I don't want to, pick a doctor, I want to have 3 doctors. What is that staff member supposed to do? And you can talk about that as a team and say, okay, well, if that's the case, just leave it at that. Send me a message, and next time I see the patient, I'll talk with her about this, about continuity and the importance of continuity. So that's kind of generally what we think are some of the physician roles in this. And some of you might be more involved in this and do a little bit more of the work, the hands-on work yourself. So here we're going to talk about what a process might look like in your clinic. So the process might look like your panel admin. So let's say one of your MOAs is downloading conflict reports and reviewing it with certain members of the team, and that might be you, that they kind of review it with, and kind of you might go through it and say, okay, let's call these patients I know aren't mine, et cetera, and sort them. The team might decide how they want to sort them. Like we talked about how you can use Excel or something to decide the order in which the conflicts appear on your sheets so that you can decide which ones you want to tackle first. And then once we know which patients we need to call to confirm attachment, you might have MOAs do something like 5 a day where they kind of call patients and ask them who they want to have as their doctor. And then if they find out that, oh, it is actually our clinic, in fact, send a fax to the conflicting clinic, letting them know that we've confirmed that and asking them to unpanel the patient from their EMR. And if the patient is not our patient, then of course we can just unpanel and maybe make a note in the chart that the patient said they're not our patient anymore. And then we talked about kind of if there's any situations where it's more complicated, maybe they should escalate that to you to talk with the patient about it at another time. And then there's an optional step. There was a clinic that I received a fax from after I sent them an unpanel request, where they sent me a fax back and said, yep, thanks, we've unpaneled them. And I was like, oh, that's such a nice idea. What a nice last step to just close the loop and tell me that the patient's been unpaneled from that clinic. So I've started doing that. So when I get an unpanel request from another clinic, I just like in my EMR use like the notes to kind of scribble on the page and say, thanks, I've unpaneled them, they're your patient now, and fax it back to them just to kind of close that loop. So some of the considerations when we're creating this process is we have to keep in mind not every PCN has the resources to help us with this. Some might be very involved and others may not. And so a lot of the bulk of this kind of work, like the calling of the patients and such, is going to be clinic work. There have been PCNs that have been helping with this a lot, but it's not necessarily, we've heard from them that it's not sustainable and it's likely not going to be sustained. And so for many PCNs, you're going to kind of probably move back into more of a supportive role where there might kind of remind your clinic of how to do this, help you create a process, help guide the process, but the kind of nitty-gritty work is probably going to be clinic work. And it is important work, and it's a part of the panel management process, which is our responsibility as clinics. It's also something that those of us on PCPCM are technically being paid for, because there's that 10% extra that you get for doing stuff like this. And so that's kind of what that's meant for, is acknowledging the time that it takes to do this type of work. So yeah, just something to keep in mind that PCNs hopefully can kind of give us guidance, but most of them are not going to be able to do all of the little phone calls and stuff that need to be done. So a few more considerations and things to keep in mind is that, again, our goal isn't necessarily 0. Maybe 5% is a good goal for your clinic, and that might take a lot of time, and that's okay, as long as we're kind of chipping away in the right direction. We also want to keep in mind that we don't necessarily want to remove a patient without confirming with the patient, but I think there are some exceptions to it. So we call it bulk unpaneling. Like, for example, if you decide that everybody that your clinic hasn't seen in 5 years, you're just going to unpanel them because they're probably not your patient anymore, that is somewhat reasonable, but you might need to, and that's what I do. Like if it's been more than 5 years, I just kind of unpanel them. But then we do have in our clinic the policy that if that patient decides to come back, that, the staff sends me a message and says, oh, this lady wants to come see you again. And I just say, oh, sure, she can. That's fine. We'll repanel her. Because I've never actually sent the patient a notice saying that I unpaneled her, because I haven't seen her in 5 years. So because the CPSA says if you haven't actually communicated to the patient that you unpaneled them, you can't technically say you're never going to see them again. You kind of have to either accept them back if they want to come back, or you have to have sent them a letter saying that they're not your patient anymore. So if you do bulk unpaneling, that is okay. You just want to kind of keep that door open if the patient wants to come back to you and switch back to you. Another thing to keep in mind, it's good to keep doing that validation and confirmation anytime you confirm attachment. So being familiar, your staff being familiar with how to validate or confirm patients when they check in for appointments is important, so that it constantly updates that on their CPAR on your list as being a validated patient, recently validated patient. And lastly, PCPCM physicians that are near that 500 patient panel threshold probably need to pay a little bit more attention to conflicts and conflict resolution. So if you're kind of close to getting under 500, we don't actually know for sure what is going to happen with that. If Alberta Health is going to say conflicting patients don't count towards the 500, we're not totally sure yet. But so it's something to keep in mind that if you're close to that and you have lots of conflicts, you might need to clean up your conflicts, see how much space you actually have, and then if you need to add a few patients to keep yourself over that 500, you might need to do that. All right. So in terms of creating a process, when one of the things that we've heard is sometimes happening, and I'm sure it's a very small percentage of people that are doing this, is that physicians are advising their staff to call patients and sometimes say, you have a conflict and we need you to stay our patient. And so please let your other clinic know that you're not seeing them. And yes, you're our patient. And that's not really what we want to encourage because patients do have the freedom to decide who they want to see, of course. And so when we're making those outreach calls, we want to make sure that we're telling patients something more along the lines of, we're just trying to confirm who you're seeing. And if you're seeing the other clinic, that's fine. We're just going to take you off our list for now and kind of do things more that way. So we do have a suggested conflict telephone script that will be included in the email resources. And that might be a guide that you use. And in terms of kind of reaching out to people, it might be best to start with the ones that are more obvious, where it's kind of like there's one patient, the patients that are clearly not being seen by the other clinic for a really long time or something like that. And again, like if the staff member is having trouble with the patient and the patient's not quite understanding, then maybe having that policy where then the staff member is just going to leave that for the physician to discuss at a future appointment. And an important thing to keep in mind, of course, is that preventing conflicts is as important, if not more important, than this cleanup. Because if we're constantly creating more conflicts by not having the right process in our clinic, we're going to have this never-ending battle of trying to clean up conflicts. So, very important for walk-in patients to make sure that you know in your EMR how to label them as a walk-in versus a paneled patient, and make sure that you're not paneling the walk-in patients. And then if you're part of a specialty practice, again, making sure that those patients are being labeled in the EMR as a referred patient or a specialty patient and not part of your panel if you do kind of both types of work. So there's lots of resources on EMR specific situations and how you actually label things that will also be emailed if you're not sure. And yeah, this is again just a note about making things easier for yourself and your clinic by looking at patients that on your conflict list that haven't been seen by you in a long time, and then maybe just deciding to remove those without kind of going through phone calls and all that kind of stuff, because those are probably not your patients if it's been a long time. So a little bit of myth busting we have in store for you next. So some of the things that we've heard is that physicians are sometimes concerned that if they unpanel a bunch of patients, it will reduce their PCN's funding because PCNs have thus far been funded based on patients paneled to their doctors. And so that is actually fiction because PCN funding is actually not based on CPAR data, it's based on billing data. So CPAR panel sizes don't affect that. I know that's confusing, and why are there so many different types of panel sizes from billing data and CPAR data, and why? I don't know, but it is what it is. So PCN funding, you don't need to worry about it because it is not based on your CPAR panel size at all. Another concern that some docs and clinics have is that what if this patient that I unpanel, comes in for a walk-in to see me again and I can't see them or bill for them? But in fact, you can unpanel the patient and you can still bill for them and you can still see them as a walk-in. They'll just be labeled differently in your EMR. So that part will be fine. And lastly, people are concerned, well, what if the patient wants to come back and see me again and now I've unpaneled them? Well, as you mentioned, if they come back and see you, that is okay. You can decide that you're going to take them back, and then they can maybe unpanel from the other clinic if they decide to see you after a little while. So we know that this is a big task and that some people are maybe feeling a little bit overwhelmed by it. So we know that some of the concerns that people have when they are working on these conflict lists is that we've heard that some people are doing really good job of like sending out their conflict notices to their conflicting clinics and saying, please unpanel this patient. I talked to them, they're my patient. And the other clinic is not responding and not unpaneling, and this patient keeps showing up on your conflict list forevermore. So that is happening. It is a very small percentage of clinics that are not responding to people's requests. Most are doing a really good job. Some of the clinics that are not responding, there are people working on that and trying to figure out, is there an education issue and what the issue is. And some of the clinics that have really, really high conflict rates that clearly have some kind of process problem are going to probably be individually contacted to try to rectify the situation. So yes, that's frustrating. It's a very small percentage of people, and we're trying to find solutions to try to get that to be even less people that are doing that. And then other barriers are, of course, that, sometimes it just is a long list and it's a lot of work. And how are we going to do this? And, all of our clinics are probably understaffed. And so it does seem like a lot, but it is, like we mentioned, something that over time is going to get better and better. And the report is going to get smaller with time. So it might look like a lot at the beginning, but overall, it's going to get smaller with time and not be as bad. Once you kind of reach your maintenance 5%, hopefully, it'll just be a little bit of cleanup once in a while. By cleaning up your panel, you'll probably have less other admin tasks. You're not getting kind of messages and reports on patients that aren't yours. So that will hopefully lower admin burden for you as well and free up some time. There's, solutions like the bulk depaneling of patients that you haven't seen in a long time to help speed things up. And that, this isn't something that we expect everyone to be doing in a month. Like our clinic, we're working on this for now a year, and we're still working on it. Like it's going to take time, but we're always kind of doing a few a day, and every month we're hopefully getting less and less conflicts. All right. So we have a couple of examples just so people understand a little bit more about processes and how they might do it. So in this first example, this clinic has it so that the panel admin downloads and prints the report, and then they kind of sort it. They've decided they're going to sort it by patients that haven't been seen by the conflicting clinic in the longest amount of time. And then the physician reviews that list and marks which patients they think should be unpaneled because they know they're moved, and which ones they think we should call. So then the panel admin or the MOA contacts those patients with a scripted call and then either removes them from the panel or faxes the conflicting clinic to ask them to unpanel. And then whatever the outcome was, they kind of make a note in the chart. The second example is similar, but the panel admin here downloads and prints the report. And in this situation, the doc wanted to be a bit more hands-off. They didn't want to go through the list themselves. So they had a meeting with their team and said, you know what? You guys look at the list. You kind of look at what makes sense. If the patient hasn't been seen in 5 years, just depanel them. And these are, the patients that have been and they're in conflict, give them a call and you guys decide which ones are unpaneled and which ones are being sent a fax to the conflicting clinic based on that conversation with the patient. And then maybe at the end of the month, let me know which patients were unpaneled, or send me a task each time you unpanel patients just for my interest. So if you're a doc that wants to be more hands-off, that might be the approach that you take by giving your staff a little bit more of instruction and power to kind of just handle this list on their own. So it takes a village in this situation. And so what we mean by this is that for good paneling practices and improved continuity, we also want to be good to our peers. So if we are getting unpanel requests, you would want to, of course, unpanel just as you are hoping others do. So and maybe sending a note back. I think it's nice communication, but you don't have to. If you don't, and if you disagree with the panel, unpanel requests, like you're like, oh, I just saw this lady last week. Why are they sending me an unpanel request? Then maybe you follow up with the patient to just confirm and figure out. But in most cases, I think when you're getting an unpanel request, it probably is that the other clinic has confirmed, and removing that so that everybody is working towards this together. So we promised we'd talk a little bit about funding because I think that's on everyone's mind. So to begin, we're just going to talk a little bit about the PMSP. So this is not the new payment model. This was like a program, panel management support program that came into effect a few years ago for people who had a panel. I think you had to have a panel of like, I don't know, 500 or something, and then you got a certain amount of money quarterly. So you get like something around $2,000 every quarter for having a panel. And um, and so there's some concern that if we are unpaneling patients, we're gonna kind of see a decrease in that funding. But what I just learned is as well is that this program is going to be ending in 2026 March. So that's right around the corner. So it's not really relevant in that sense anyway, because this program is ending. But just for our knowledge, this funding is actually allocated via that four-cut method using billing data. So again, yeah, we're getting panel sizes from all kinds of different methods, but for this particular payment, it's not your CPAR panel, it is your billing data. So by cleaning up your panel conflicts, you are not going to see any change in your PMSP funding, the remaining of it for the next 6 months. So it won't have any impact. All right. And then in terms of those of us here that are on the fee-for-service model, cleaning up conflicts does not impact your funding at all. So you don't have to worry about any, by getting rid of conflicts and resolving conflicts. It does not impact your funding or your payments, but it does impact your patient medical home. So if you have a more clean panel, that's kind of one of the first steps to having a good patient medical home. Again, all of the benefits that we talked about with having a clean panel. So you don't need to worry about income, which is nice. But on the next slide, we'll talk about PCPCM PEEPs. So myself included, starting in April 2026, which will be the 1-year anniversary of PCPCM, patients that are in conflict may not be paid the panel payment part of our payment. So the monthly panel payment we're getting, patients in conflict, they are saying are not going to be paid. So this is going to result in some of us seeing a little bit of an income decrease, and some people probably seeing a really big decrease because some people have really big conflict lists. So it doesn't necessarily benefit people to hang on to patients in conflict, because whether you unpanel that patient in conflict because you were asked by the conflicting clinic to do so, or you haven't seen them in forever and they're seeing someone else, or whether you hang on to them and keep that conflict, you're not going to be paid for that patient. So we may as well all do our part in cleaning up conflict, because then at least one of our colleagues is getting paid and the right person is getting paid for that patient. We don't know for sure yet whether, again, those conflict patients are going to count towards the minimal panel size for eligibility. So for now, we do recommend for those of them in the red alert zone that are having panels close to 500, that they keep an eye on that and maybe make sure that even in spite of conflicts that, they still have enough patients that they're not going to, in April, suddenly not be eligible for PCPCM if that's what Alberta Health decides to do. We'll go through a couple of more funding examples here just to help with any thing that wasn't too clear. So here we're looking at an example of a patient named Bob who sees two doctors, Dr. A, who's on a fee-for-service, and Dr. B, who's on PCPCM. He sees Dr. A because he's close to his house and sometimes goes there for a walk-in when his regular doctor can't see him. And his regular doctor that he sees for almost everything for many years is Dr. B. So if both of these docs are paneling this patient, Dr. A and Dr. B, then once April rolls around, Dr. B isn't going to receive panel payments for Bob anymore. Dr. A doesn't really affect him either way. So ideally, Dr. A would, if Dr. B sent him the unpanel request, Dr. A would do so. So that's one example. Our next example has a patient where he has two doctors. He has an old doctor, and then he recently moved to his new doctor, Dr. B, but he never told Dr. A. So he moved, and both of these docs have Mohammed paneled onto their panel. So when April rolls around, neither of them are going to get the panel payment. So hopefully this conflict can be resolved by when Dr. B is doing a kind of a panel project, or Dr. A is doing a panel project, they will determine that this conflicted patient is now seeing Dr. B, and Dr. A might decide to unpanel them. And in our third example, we have Maria, who has two doctors. One of them is on fee-for-service, and one of them is on PCPCM. She's just seeing two people for no real reason. She just likes getting second opinions. So we all have patients like this. And, Dr. A is on fee-for-service, so it's not really benefiting her to keep this patient, Maria, on her panel. Her name is Maria and also Amy. Amy is her middle name. Dr. B may not get panel payments for Amy either. So hopefully one of these docs, is doing a panel cleanup and decides that they're going to talk to Amy, about her seeing two doctors and try and figure out why she's doing that and give her a bit of education and help her decide. But if she doesn't decide, what can you do? She might be one of those 5% conflicts that we just tolerate. All right. So we wanted to talk a little bit about how those of you that might need to do your PIP activities. So we all have to do our CPSA practice improvement project activities. We have to do activities every 5 years. If this is sounding unfamiliar, don't worry. We have lots of resources about that too. But we all have to do these activities every 5 years as part of our college requirements. And you can actually use this conflict cleanup work as a PIP activity if you want. So it can qualify as either the practice-driven QI or the CPSA Standards of Practice QI. Either of those, if you need one of them, this would apply to. There's the third requirement, that's a personal development activity. I don't think you can really make this work for personal development activity, so that one you'll have to do something else. But yeah, either of the first two you can do. So how would you do them and how would they differ? So if you're doing it for your practice-driven QI, you just kind of make a goal of what you want to change. That might be reducing your conflict rates, make a process, do the process, and then remeasure it later and see that your conflict rate has gone down. And that's kind of how a practice-driven QI works. The standards of practice one would be fairly similar, but the difference is that you have to review one of the standards of practice that applies to conflicts. And Trevor went over those at the beginning, so you can always relook at the slides so that you can remember which standards of practice that the college has apply to conflict cleanup work. So you just kind of read that, and then you do a similar project where you look at, okay, my conflict rate is 10%. I want to get down to 5%, or I want to get it down to 8% in the next 6 months. And that's what I'm going to work on. So they are similar. It's just that the standard of practice one, you review the standard of practice that applies. The rest of the process and the documentation is the same. So yes, you do an action plan, you do the process, and then you report and record the outcome as your conflict percentage monthly. And then on the next slide, we have a lot of words. Don't worry about reading. This is going to come out to you. We just wanted to include an example of action template because this is how we record PIP projects. Kind of make a SMART goal. You talk about who's on the team that's going to work on this. What are the barriers? What are you going to measure? And then that's kind of how we record that we've done a project. And this is what you would do to record either the QI or standards of practice project. All right, we did it. So we are just going to talk a little bit of review and then we'll take some questions. So to debrief our mission, it is in all of our best interests to reduce the number of conflicts because it's good for patients, better continuity, less admin burden for us, and we have more accurate panel sizes. One of the most important things is that removing common types of conflicts will not negatively impact your income, but it might increase some people's income when we work on these conflicts. It's really important to avoid conflicts by not paneling patients that aren't your family practice longitudinal care patients. We all should do our part by honoring requests from other clinics to unpanel. And we are not in it alone. We want to use our team. We want to work together on this to make it easy. And if we need to do a PIP activity, if our PIP activity is still due, we can use this as a PIP activity. So this is just a list of resources. Again, we're going to email it all out, but it kind of has a lot of information about, CPAR and conflicts and all the templates that we have, how to panel people and label people properly in EMRs, all kinds of great resources, as well as an email at the bottom there. You can email if you have questions, specific questions once you start doing this work. All of these resources and this presentation was made by a really great team from ACT who has been working on this stuff so hard. So I really want to thank them, Robert and Emily and everybody else that's in this from ACT here that's working on this all the time. They do such a good job. So thank you all for listening and for being here because, I think the people that are here are, the more motivated people that are kind of really trying to work on this. So I really want to acknowledge, thank you for the work you're doing and for being leaders and getting started on this. And we're hoping that with time, this becomes the norm. And so we're going to take some questions. I'm going to hand it back over to Dr. Prince, who's going to moderate the Q&A.
All right. So as I mentioned, we will start off at least trying to do the hand raise. If you can't see that, it's on the bottom. Mine's under a little heart that says react. If you click on that, then there's a thing that says raise hand. So we'll watch for a minute or two, see if anybody has a question that they'd like to raise their hand for. There have been some in the Q&A typed in there. We can certainly go to those. Dr. Lepe.
Good evening. Thank you for this presentation. Quick question. If I have a patient walking come to see me as a walk-in, or like one of those convenience patients who just wants to see me but has got a doctor elsewhere, how do I bill for the patient then? Like, I don't want to panel the patient because it's just seen me as a walk-in. What do I do?
Are you a fee-for-service physician or a PCPCM physician?
PCPCM.
I see. You can just bill the normal codes for time and encounter, and then the only difference is you just won't get the panel payment for that patient.
So do I need to switch my BA number to, can I still use the BA number that I use for my PCPCM, or do I have to use the old BA number?
You got it. You can use your PCPCM BA number.
Okay. And then how do they know it's a walk-in patient? Okay, okay. But then I can't use, okay. So I get less payment for seeing that patient because it's not on my panel.
So you would miss that 20% panel payment if you think about the 40-40-20 as the total breakdown. But then absent the panel payment, the time-based component and the encounter-based component is roughly the same as fee-for-service. So it's roughly equivocal, where you would get about the same amount if you were billing fee-for-service.
Okay, thank you.
Excellent. Thank you. I don't see any hands, so maybe we'll go to the Q&A. Dr. Elkink poses a question. I think the first part has been answered. If a patient's been paneled on more than one list, currently both are getting paid. Come spring, obviously only one would get paid. And then the question that I believe was unanswered is about the 500 patient minimum. And I guess her question then would be, if AHS hasn't been clear about this, when will they be? Who's got their crystal ball out?
I think Dr. Baines used a great red alert reference. So maybe Dr. Baines, do you want to throw that one out there again?
Yeah, I think we just don't really know, unfortunately. But I think, the best thing to do would be if you're pretty close to that 500 and your conflict list would put you, if you minus your conflicts from your panel size and you're going to be under 500, then I think I would feel probably more motivated to work on my conflicts and resolve those conflicts so that anybody that is actually yours is no longer in conflict by April. And then you'll know if you need to add a few patients, but we just don't really know. And I don't know when we're going to know. I don't think if anybody from ACT has more information on that, they can pipe in, but that's my understanding to date.
Okay, hearing nobody jumping in from ACT, I'm guessing that means they don't have any more clear information than you do. Next question, I think as well was answered fairly well, but just the frustration of what do I do when I've done everything I can and people aren't taking them off of their panel. It's from Dr. Henderson.
It certainly is frustrating. I hear that frustration. I don't think we have a really good answer for you in terms of this is exactly what you do and this is the process. There have been discussions about dual attachment versus hierarchy of, if a doctor is PCPCM, do they then win the attachment if there's another attachment to a fee-for-service doctor, et cetera? But there hasn't been any hard and fast rules that have been developed by government. I think it's something that we're hoping to have sorted by April 1st of next year, which is obviously like 6 months away. So it's coming very fast. So certainly lots of ambiguity and lots of unanswered questions, but it's something at least we're trying to work on.
Thank you. I have a hand raised, Dr. Elkink.
Yeah, follow-up question. Sorry to be a pain about this. I guess I understand Alberta Health is dilly-dallying. How hard are you guys pushing on this answer? And this is actually not for me. I'm very well paneled, but there's lots of people that I work with who are like at that between 500 and 600, and they're like walk-in docs are not taking patients off, and they're like, and the problem is like if they panel patients, if those patients are double paneled, like they could take on an extra 100 patients, and if they run into the same problem, they're going to have too much work, right? Like that. So I guess my question to you guys is how hard are you guys pushing Alberta Health to get an answer on this? Because it does impact a good chunk of people, I think.
Yeah, so from a section of family medicine point of view, I'd say we're pushing quite hard. The issue that we're running into is Alberta Health is not greatly motivated to engage with us at this moment. And so part of the genesis of the webinar this evening is us thinking, okay, so if we can't control Alberta Health's level of engagement, what can we control? And it's how we clean up our panels, our panel hygiene and all that stuff, hence why we're bringing you this content this evening. But it certainly is a risk, and you're absolutely right. And we are trying to get them to talk to us more about it and trying to come up more with a plan. It's sort of like when you're trying to get someone to quit smoking and they're pre-contemplative or contemplative, and your counseling just falls on deaf ears. That's kind of where we're facing. Although as the time ticks past, perhaps Alberta Health will become increasingly motivated to talk to us about this.
Thanks.
Thank you, Dr. Gill, Charmaine Gill.
So I have a question. Actually, I have two. My first question is if when the payment of PCPM, I'm not sure if I'm saying it right, and you're looking at the panel size, what is the duration of the panel that you're looking at when the payment's being made? And my second question is, I recently moved my clinic, and the PCN is still hasn't put up my CPAR till yet. So it's been over 3 months. Is it just the PCN coordinator that deals with that, or is there someone else I can reach out to establish my CPAR?
Emily or Robert, would one of you folks like to answer her questions?
Sure, I can answer the first part, then I'll pass it to Robert for the second. So for your panel payments, they are calculated, it's back calculated. So for example, if you're on, say, AVA, EMR, and your panel uploads on September 2nd, you would not be paid for the panel that uploaded on that date, that CPAR, whoever was in your CPAR panel on that date, until October 31st. It's the last Friday of the next month. So it's quite behind. So it just captures point in time on September 2nd, whoever was in your CPAR panel, and that's who you're paid out for the last Friday of the following month. So hope that makes sense. So say you paneled a new patient on September 5th, that patient wouldn't be captured until November in payment. So it's quite behind. Robert, oh, sorry, go ahead.
Yeah, so my patients, like I have a big panel. So, patients that were not listed on my CPAR for those 3 months, would those patients not be included till September 2nd?
Yeah, it just captures that point in time, whatever is in your CPAR panel on the date of upload. And you can let us know what day which EMR you're on, and we can check that date. They all upload before the 20th of the month. So it's just a point in time, whoever's on your CPAR panel on that date is who you're paid for, up to 8 weeks later.
So med access. So
Actually, maybe can we just have Robert answer the second part?
Sorry, what was the second part, Dr. Gill?
So it was like, my CPAR has still not been established. And that was being done through the PCN coordinator. Is there someone else who could help me in putting that up?
Yeah, absolutely. So I see you're not quite live at your new clinic location. I will reach out to you through our CI CPAR inbox to see if we can work with your PCN to get you fast tracked to getting live on CPAR.
Thank you.
You're welcome.
Dr. Hodgson, Craig.
Yeah, hi. Can you actually hear me? I'm sort of on a phone and on a computer.
Yes.
You can hear me? Yeah, so
camera, we'd love to see that too.
Oh yeah, so I can find that somewhere on here. I don't do this much anymore. And now I don't remember how to do it. There we are. Yeah, I just say it because I moved into Edmonton almost 2 years ago, and I had a problem because, and this is more related to the previous speaker, and that I came off the PCN where I was, eliminated me from all my patients. So I lost everybody. And there were a few people that I actually did see in the city, and it took months to get things back on because I didn't get admitted, though I joined the clinic here. I didn't get admitted to the PCN until they had their next board meeting, and they would not upload anything on me until that was the case. So it delayed me for 2 to 3 months, essentially. So I don't know for Dr. Gill, she's in the same PCN. I don't understand the delay. If she's in a different PCN, she may need to talk to the PCN people, because I got delayed because they didn't admit me to the PCN right away, and they wouldn't upload any of my CPAR.
Oh,
Just another thing. I don't know if that's her or not.
Yeah. Thank you. I'm at the PCN's West Central Calgary.
And Dr. Hodgson, having the Flames banner in Edmonton didn't cause you troubles at all? It's in your back.
No. Oh, I've got a Flames one I can't even see. Oh yeah, you know what? It's supposed to be for my nephew who's down there, but no, I've got jerseys for both Edmonton and Calgary that I wear to different games, sometimes just to entertain people.
Oh, you're okay then.
Yeah, thank you.
I'll just
we'll
add here,
take a
sorry, Dr.
question off
Prince.
of.
Sorry,
Sorry,
just
go
add
ahead.
one more piece of context there. Your PCM membership shouldn't affect your ability to join CPAR at any time. It might affect when your PCN decides to help you get on board, but we have non-PCN family physicians live on CPAR. As long as you can find someone to submit your CPAR paperwork to the health team, we can get you on board to CPAR fast. If you're having problems with your PCN support doing that, then reach out to the CI-CPAR at albertadoctors.org inbox, and we can help you through that.
Okay. We'll go, I don't see any hands raised. We'll go to the Q&A. I'm going to take one from Dr. Akinsipe, I'm guessing. Sorry if I said that wrong. I have a patient who I've been taking care of for well over a year, but on Netcare, no provider is assigned, or sometimes a different provider is assigned. How do I get it resolved, especially when there's no provider on Netcare? I'm guessing she's been taking care of the patient. The patient does not show up as having a provider on Netcare. Or somebody else shows up occasionally, it sounds like.
So I think, Mercy, you might have to see if that patient is not uploading to CPAR for some reason. Sometimes there can be issues like what's called a demographic mismatch, like if in your EMR, the birth date or the last name or something is not matching Alberta Health and what their healthcare card says. And that might prevent that patient from uploading onto CPAR, and then they're not being counted as your patient. Depending on what EMR you're on, like AVA has a feature where you can actually see which patients are not uploading onto CPAR, and then you can figure out why they're not uploading. So if this is like a one-off thing, you might need to look into, is there an issue with the demographics? Has the patient been seen? Has the patient been validated? So yeah, Amy also commented on the validation. So all of those three things, like demographics are correct, and matching their Alberta healthcare card, the patient's been seen by you at least once and been validated at your clinic at least once. So it's probably just an EMR thing.
Thank you. We don't have any, I don't see any hands raised. The next question isn't exactly germane, but I'll leave it up to the panelists if they would like to deal with it. It doesn't deal with conflict, particularly looking at a philosophical from Dr. Elkink again. What is your sense of the responsibilities AHS will hold us to for our panel patients going forward? Things like access and screening. So the reverse of paneling being an advantage to patients are assigned to me is Alberta Health going to expect different performance or have expectations on what I need to provide to my patients? Demands, I guess. I'm extracting, is that correct, Dr. Elkink?
Yeah, I'm just looking at the flip side because that's the one thing that holds, not to beat up on walk-in docs, but walk-in docs who are paneling people that they don't treat regularly. And I know I'm asking a philosophical question, but you guys are the ones at the table. What do you guys see coming first? Because there will be responsibility requirements eventually.
I'll leave it to the panelists if you want to take that on now.
Trevor, I can see you smiling, Trevor. Spit it out.
Actually, I don't know. I have no idea. I was just thinking about how, like, perhaps position-wise, I'm the one closest, and yet I have zero idea. I have no idea what's coming down the pipeline. So I'm sorry, nothing to spit out. I feel ignorant.
Oh, it's fair. Thank you. Andy, do you have any thoughts?
I have no ideas, but I mean, if I was government, I would probably implement some measures because I don't think it makes sense for people to panel huge numbers of people and not be taking care of them. So, I mean, it makes sense that that would be coming, but I don't know anything about that. But I think if I had any power in it, I would have some accountability measures where you need to have reasonable access and reasonable continuity numbers, which we can access through the HQCA reports. It tells us what your continuity rate is. It tells us what your clinic's continuity rate is, what your screening rates are. So I would leverage that data if it was me. And, if people are not looking after their patients, maybe have some kind of bonus for people who are, or have some kind of penalty, a mild penalty for people who aren't. But we have no idea if that's happening.
I guess Andy gave a very thoughtful answer. Well done, Andy. I guess one thing too, as we move into negotiations for Agreement 2026, this might become more apparent in the coming months. So I guess we'll find out. But we do know, at least historically, government is very interested in access, hence opening up primary care to many historical non-primary care providers.
Another question, a bit of a technical question. How do I find out my panel size? From Dr. Said. On AMA website, the number that's showing up is from April.
So I think there'd be two ways. If you can log into your CPAR panel, like if you're the panel administrator or you ask your panel administrator to log in, I believe it will tell you exactly how many are on your CPAR panel. And then I think also too on your PCPCM statements, it'll tell you what your PCPCM panel size is. So those would be the kind of the two main ways to figure it out.
I'll just add too, government is no longer giving us updated panel sizes for PCPCM participants. So how you went on to the AMA dashboard to express your interest to get the application form, they're only continuing to update that data for non-participants. So it's not a good source of truth any longer to use the AMA dashboard for your panel numbers.
Thank you. I have a question from Dr. Adabi. Is it possible for PCN to remove doctors that have retired from CPAR? This might be one of the reasons that we don't get response after sending letters out. Not sure if retired doctors are a big chunk of the problem, but I guess the question is, once somebody's retired, is there a way to automatically unpanel them?
So I can take that one if you like. There are cases where this happens, where someone moves out of the province, stops practicing suddenly for some reason, and they don't terminate their panel. If that does happen, I would again suggest you reach out to our team at CICPAR@albertadoctors.org. Let us know confidentially what the name of the physician is and the clinic location that you believe is being affected. And then we have a process with eHealth to kind of bypass the usual authorizations. We'll confirm that the doctor is actually retired or left the province, and then eHealth will actually terminate the panel.
Thank you. Another kind of technical question, and I think it was partially answered, how is the amount for the panel decided for each month? Is it divided per month from the total panel or the patients I see for that month? I think Dr. Baines, you answered this a little bit earlier, that the number on the panel, the last upload of the panel when they take it on the 20th or whatever day that is, that's the panel number that they use, not the number of patients you've seen that month. Is that correct?
So sorry, is the amount for the panel decided for each month? Is it divided per month? So yes, I think Robert was answering that question. Like there's a little bit of a delay in the uploading of the number, so by about 2 to 3 months. But yes, whatever the amount of patients that are on CPAR in your EMR that are being uploaded, say in July, it takes a month for them to kind of upload, and then it takes another month for them to go and transfer that information to the PCPCM payment model. So then that updated number will be reflected a couple months after a change is made. I think that was the question.
I believe that
Okay.
is the intent of the question, yes. Thank you very much. So a bit of a delay there, and Dr. Patterson's posted it takes a couple of months after your latest upload for that number to actually reflect the payment amount. Well, we're nearing our time, and I see no further questions. I think we can wrap things up. We'd like to thank our panelists for taking the time for doing the presentation, encouraging us all to get our panels cleaned up and some suggestions on how to do that. Any final questions, Dr. Day or Dr. Baines? Or comments, sorry.
I just want to thank everyone for taking the time to come join us this evening. I know paneling isn't the most exciting thing on a Tuesday evening, and I'm sure there's other ways many people would like to spend their beautiful time. But thank you for coming, and thank you to AMA-ACTT team for putting all these resources to help us out with this and to get these numbers down.
Thank you. There is a poll that's showing up. If you have a moment, please take that poll. That's very helpful in planning future events. Thank you. Have a good evening.